Good morning. We're hoping that everyone can hear us. If for any reason at any time you're not able to hear, please let us know. We are going to be queuing up the PowerPoint right now so that you are able to follow along with us as we're getting started. In the interest of time, we are just going to go ahead and jump right in, but certainly as questions are coming up, please send them through and we'll try to answer them as we're able to.
We know that some folks sent some questions ahead of time. And so if you happen to be one of the participants who did that, we feel pretty confident that we can interweave those into the presentation. If you feel like the question isn't thoroughly answered or you have some more questions, know that you can absolutely probe us some more at the end of the webinar.
All right. So the first section that we're going to be discussing right now is really looking at just starting with understanding the victim differences. So we understand that children with special needs are much more at risk for being abused. Unfortunately, we don't really know what the rates are. The rates really vary. Some say 7 times the normal rate, some say up to 10 times the average rate. And so right now what research is kind of telling us is these are all things that they're guessing. Most of these crimes are underreported. And so even when we know something has happened, we don't really have the statistics or the data to show us what those real percentages are. And when we talk more about this victim population, I think it'll become very clear why this is being underreported and why this is such a difficult area for investigators and prosecutors to be able to make further steps of action to protect this victim population. So when we are talking about this area, we're going to be talking a little bit about dynamics of grooming. So when we think of grooming, we know what a standard grooming process looks like for a typically developing child. What we want to really delve into are the differences that kids are having when they have already had really early exposure, not only to adult-child interactions through, therapy or early intervention programs or medical treatment, but in addition to that, they're having much less education around what types of touch are appropriate, things about their bodies. A lot of times these children are seen as not being at risk because they are seen as kind of permanent children. Even when they are older, teens and adults with special needs rarely get education for changing bodies, healthy relationships, things like that. So it keeps them at a really high risk level because this is something that's just not being brought to them. Very few special education programs have protocols that the teachers are able to implement to teach these kids this information. And then the second part, we'll be looking at the considerations for trauma processing. So for a lot of these kids, they may have very similar trauma responses as a typically developing child would. We're not saying that everything that they go through is different. What we really are looking at is how their unique experiences and how their unique really regulation system and sensory processing system is going to affect if they either react at a heightened level or at a diminished level based on that kind of unique responding pattern.
Well, and what we want you to know is we're going to go through before the end of this webinar is we're going to really help you understand some common special needs among kids. And I will really walk you through how that may show up for you in a forensic interview or in an investigation. So then you know how to modify that process for yourself, but that will come later.
So starting with grooming, I just want to walk you through one of the kids that I've worked with and just kind of be having you think about what her experiences, especially early on, are going to do in terms of priming her, not only for grooming, but for underreacting or under-responding to some of that trauma that we would expect another child her age to have a much more noticeable reaction to. So this is a review of Ava. So she is a baby born premature with a diagnosis of Down syndrome. She had to have surgery right after birth. She had a congenital heart defect. And then the doctor told her she would need continued surgeries over the next 5 years of her life. She had difficulty with feeding, which is not uncommon with this diagnosis. And so she had to have an NG tube or a nasal gastric tube fed down her nose as a way for her to have consistent nutrients and calories. When she was discharged from the hospital, her parents then had to keep her on a nasal cannula just to provide oxygen continuously at a 24-hour rate. So what we want to really think about is from the beginning, so from birth, what is her brain learning in terms of pain and how to tolerate pain? Because what we know about the brain is the brain's job is to help you survive. If it is sending you signals and it's not changing any of that input or information, then your brain is going to start muting some of those responses to pain to help you. And so when children have a lot of medical intervention, especially early on, over time, they can have a decreased response to pain as a way of their brain helping them manage that experience that they're having repeatedly.
So think about Pavlov in your one psychology class, right? You don't have to be a psychologist, but think about Pavlov and training the dog, right? So that's what we're doing. And so I'm not saying that to be insensitive, but understanding that our bodies and brains will adapt to that. And that's what's happening to these young people really early on, where we bank on some of those not those adaptations not occurring, and that's how we solicit information or understand that something is wrong with somebody, because they wouldn't be exposed one way or another. So when we're asking kids, whether we're child welfare therapists, investigators, whatever, we're asking kids about did something hurt, did something scare you, did something whatever. So all of those cues don't work for this particular population because that is their normal.
So then looking at, knowing her health history, how many adults outside of family members are going to be involved in touching her body? And you can imagine it's going to be a very high number. It's going to be cardiologists, nurses, physician's assistants, anyone that needs to, check her out to see how she's doing. And I will say, doctors go a long way to try to help the child feel as comfortable as possible. They want the parents there. They want the parents holding them. But at the same time, because this is a medical necessity, if the child is crying or is dysregulated, they're going to have to hold them down at some point, or put them into some kind of a position where they can do what they need to do because it's required.
Think about, I have a kid, a 4-year-old with pink eye right now. And so that is the situation I am finding myself in over and over again, because naturally he doesn't like eye drops. And so that is occurring on a regular basis.
Yeah, so these people do not have malintent, and unfortunately there's really not too much they can do different than the strategies they're already using. But again, this is informing her brain that this is a level of intrusion and touch to her body and manipulation to her body that is out of her control. And again, over time, there's really no point in fighting it. Last, kind of this bottom section here, how are these earlier experiences differing from what a typical baby her age would be experiencing? When children are full term, when they're healthy, when we don't have this added developmental and medical piece to it, most infants are just with their primary caregivers. They're going to be spending a lot of time with their parents, maybe a grandparent coming over to help or a family friend. But for the most part, they have a very limited circle of adults interacting with them, and especially adults who are going to really be doing a lot of bathing and diaper changing and things like that. And so in addition to that, if they're upset, most attuned parents are trying to calm them down. They're trying to stop whatever is causing them to be dysregulated. And so it's informing them that crying is functional. You're telling me that this isn't comfortable or it hurts or something's wrong, and I'm going to do what I can to make you feel better. So very different from what a child with special needs, especially medical needs, is getting, right out of the gate. And really what she's learning through this set of experiences is that reacting to touch, reacting to a new person holding her that's not a parent, reacting to pain is not functional. And the brain really is looking for function and behavior to reinforce it. If there's no function to screaming, crying, dysregulating, the brain stops reinforcing that as a pattern and just starts going into that shut down, shut off mode.
Many of you are familiar with this when we see kids, when we remove kids from homes and they don't cry or they're happy about that. That is an example of that showing up in a typical functioning child, and how you may see it in your day-to-day lives outside of the special needs population.
So in addition to the medical piece, obviously we know that Ava has Down syndrome. And so when we're thinking about other services she's going to need outside of medical, she's going to be getting most likely feeding therapy. We know she has an NG tube. She's going to be probably working with a speech pathologist because this diagnosis is associated with low muscle tone and motor delays. So that delays gross motor skills such as crawling, sitting, walking, all of those things, delays fine motor skills, picking things up that are small, self-feeding, and then ultimately delays oral motor skills, which is going to be communication and speech. So she now is going to have a team of developmental providers in addition to her medical team. So now that huge number of people that was already working with her has doubled. And in addition to that, a lot of these interventions that are developmental interventions can also be intrusive, can also involve, manipulation of the body, or, some feeding therapists will have to put latex gloves on and feel around in their mouth to see if they have a tongue tie or a frenulum tie, or to see how their tongue is moving in their mouths. So again, we're seeing a lot of intrusion into that separate space that she has to learn to tolerate, because again, they're not doing it with malintent, they're doing this to help her, but she's having to now learn that this is something she has to tolerate. So when we think about the early intervention aspect of this, and this is something that, this is the field that I primarily work in, so I know a lot about what that home setup is and what that therapist-patient dynamic is like. When we're going in to treat these children, we do want it to be fun. We do want it to be play-based as much as possible, but it is adult-directed, it is goal-oriented, and it's in their home. So that's a big difference between, when children go into the hospital or the doctor's office, they know that there's some level of expectation. All typically developing children are going to be going into the doctor, and that's why we know some of them cry, because they know it can involve shots or, different types of checkups that make them uncomfortable. But they start to learn over time, this really is just happening here. It's usually when I don't feel well, or my mom's told me, you have to have a shot today, but we're going to give a sticker afterwards. So there's limited exposure to that. But for children who are getting early intervention, not only are they getting that, again, repeated exposure to new adults and having more kind of physical manipulation of their body, it's also happening in their home. And so that's not going to make it feel strange or unusual if an outside adult that's not a developmental provider or medical provider is doing something to their body in the home or in the school environment. They're not going to really register that that's significant, because it happens basically for them in most of their environments. So, again, therapists are working with parents collaboratively. We are trying to make sure that they are involved and that they are helping to set the goals for treatment and voicing their concerns. But again, that also is kind of creating more opportunity for pushing in different areas that the child may not quite be ready for, because the parent feels like this is an important need to work on right now. So I have put some photos here just to show you what some of these exercises or activities in the home may look like. So here in this photo, these are physical therapists. It's probably a physical therapist working with the mom, working on, what we call vestibular input, which is getting kids used to their head changing position. So they usually roll them across things. For kids who are sensitive to vestibular changes like that, they will get upset. It's not unlike getting on a roller coaster or getting car sick. And so even though they don't like it, it's something that they need to desensitize them to so that they're able to move their bodies better. Now you can see in this picture, this child is really helpless. You don't know this from the photo, but this child has cerebral palsy. And so she is also not able to change herself out of this position. So for example, if I were to do this to a typically developing 3-year-old and they didn't like it, they would fight back pretty hard. Doing this to a child who cannot change their body position, they have to learn to accept it, because they can't move into another position. And if they cry and that cry doesn't really yield any difference, then they stop crying. This is some of the speech intervention that we were talking about, where again, lots of hands on the face or the mouth, inserting things into their mouths to help them learn how to move their tongues around, help them with building up muscle tone. So these things are all necessary and they're important for these kids. But again, looking at some of these pictures and different interventions and positions they're putting them into, you're starting to get a sense of how they may react to an adult who's not a therapist or a doctor trying to manipulate their body in similar ways and thinking that this is a normal experience. So basic session structure is going to be, following the child's lead. So kind of joining them, building rapport, setting limits. Most therapists try to incentivize them, which is a good thing. We want to give them bubbles or praise or clap for them. Some still use small pieces of candy. It has a very predictable routine to it to help with regulation, and then some side coaching of the parent, letting the parent know what to expect and letting the parent know what types of things to be working on with them. But it also is really about creating a relationship with that parent. So Keeping that session structure in mind, we want to now switch over to looking at how an offender would be setting up that preliminary relationship with the child and the family. So, in just terms of offenders, we're mostly going to be talking about preferential offenders today because they are the ones that are going to be most likely to target this population. So preferential pedophiles really go after a specific age and or gender, very organized about how they do it. They're going to find socially acceptable ways to be around their victim population. They're not trying to draw attention. This is how they are able to abuse so many children before they're caught. So given that these children, and a lot of them may have language delays, cognitive delays, are going to be considered by most people to be unreliable or inconsistent, this is going to be a very appealing victim population to a preferential offender. Also because this family system is under a lot of stress, this offender is going to have an easier time grooming the parent and developing a trust relationship with them that will help remove suspicion from the parent if the child starts acting in an unusual way.
Well, and we call that, and we're not going to talk about that today, but we talk about the difference between individual grooming and environmental grooming. So I know that you know what grooming is, but I want to give you some language that you may be able to use in the courtroom if you struggle with that. When it came up for me early in my career, people would ask me, what's the difference between grooming and flirting? And it was hard to put some language around it. But grooming is a systematic process in order to gain compliance from a victim and to reduce the likelihood of disclosure. And you know how that shows up in kids or adults who've been groomed. Now, environmental grooming is when you create a system around the victim where if you do it well, you may not even need to effectively groom your victim unless you're trying to gain compliance. But even if your victim slips and does tell, the environment around them isn't going to believe them. So it's kind of a safety net around that. And so what Courtney's trying to say is it's so much easier, obviously, to do this with families who are super desperate. And we see this among low-income populations, many cases with moms who men are offering to help out, and they take that as a kind of chivalrous way to join the family when in fact they're predatory in some way, shape, or form.
And just to kind of touch on what Amber was saying, because these families have so much stress and are so desperate just for a break, they will leave people that they assume that are inherently trustful alone with their children. And I think a lot of parents in general don't understand that it just takes, seconds and minutes for a person to abuse a child. It does not take that long. And so I've personally been in a parent's home where I was evaluating a child. They had just met me. They had been there for a little bit and then have, gone into the other room or taken a phone call and stepped outside, where I've been alone with their child for more than enough time for something to have happened. But this parent automatically assumes, first of all, because I'm female, I'm sure, but second of all, because I've also had male therapists who have reported the same thing, because we are therapists. People assume that if you work with children with special needs, you're a good person. You care about these people. You would never hurt a child. Why would you specifically go into this field if you just wanted to hurt them? And unfortunately, because there is a lack of education, not only for children with special needs, but for their parents, then these parents don't realize that preferential pedophiles are absolutely going to work in early intervention, in special education, or in foundations that support those programs for that reason. And so a lot of the education, demand is not just for the children, it's for the parents as well.
Well, and you all know, all 76 of you on this webinar, that doing sex abuse prevention education is hard anyway, right? We still have the feelings that if we talk about sex or talk about sexual abuse, that it will happen. And so we've got, that is doubled or tripled with the special needs population in resistance, where they, as Courtney was mentioning earlier, they forget that just because their child has special needs or delays in certain areas, that their body is not sexual. And again, you all know how difficult it is for adults to think of children having sexuality in any way typical functioning, and then it becomes even more complicated with this group.
So looking at that grooming process that Amber just outlined for y'all, we start with that rapport building. So again, adult introduces proximity. So for most pedophiles, they're tickling, having them sit on their laps. They're doing kind of just testing those waters to see, if I hug you and you don't like it, are you gonna run and tell your mom, or are you gonna tolerate it, and can I build up from there? They also are gonna introduce a routine around touch. You know, you always sit on my lap when you eat this snack that I brought for you, or you sit on my lap when we watch this show together. And so they're going to get more predictable about when the touch is going to happen to make it less likely for the child to react negatively. The next is going to be goal-directed interaction. So the adult is going to engage that child in that abusive behavior. So they're going to move from that borderline touch into abuse. And then they're going to set a limit around that abuse. So essentially what they're doing is they're looking to see how the child responds. Are they getting upset? Are they likely to tell? Are they threatening to tell? And that adult is going to come in with that next step of either rewarding them for not doing it or punishing them for doing it, telling them something that scares them, going and telling the parent that they did something that they didn't do so that they can show them that the parent believes them over that child. They may stop bringing them gifts or giving them attention. So they have their ways of trying to control the child's response to the abuse. And again, in the event that the child does not report for different reasons, then they're going to reward them to try to reinforce them to continue to do that. Now, if you look at the developmental therapy process, you're going to see it's exactly the same. We, as therapists, build rapport. We introduce proximity. We have to be close to them to work with them. Sometimes we have to be right next to them. Sometimes we have to be touching their face or their body. We also are going to have a routine around when and how we touch them. We're going to bring something out to show them, oh, you know what, it's time to roll on this exercise ball. And that means, I'm going to pick you up and put you on the ball and roll you back and forth so that they know when the touch is happening. And we do it for the same reason. We don't want them to be upset during certain activities that may be difficult for them. The next step is going to be the same thing, goal-directed activity. The therapist is going to engage that child in whatever behavior or whatever skill they're working on, and then setting a limit around it. So a lot of children in early intervention, especially kids who have been in it for a long time, become non-compliant. They don't want to do it anymore. And so mostly what we do is either withhold the next activity that they want to do, or we tell them, well, we're not going to move on. You can sit here and hang out, but we're not going to move on to the next thing until you finish this first task. Now, again, this is all normal. We're usually talking about them doing a puzzle or something like that, but we are building this sequence in for them. When they comply with finishing the activity, we give them bubbles or treats or, a fun toy to play with. And if they don't, now again, the consequence is going to be very low. It may just be, we're not going to play with the tablet until we finish cleaning up. So something small, but it's teaching them, if you don't do what I've asked you to do, one of two things is going to happen. And this is how you learn behavior. Now, the problem is that when we think of grooming, I do not think of children with special needs as needing grooming, because the difficult thing is that they've already been groomed by people like me. They're speech therapists, they're occupational therapists. And even though we are not grooming them, our process for intervention is exactly the same. And so regardless of the intent, this is a very similar pattern. And so this child, when an offender comes in and does the same things with them, is so used to it that their reaction to it is going to be limited based on, how that abuse is being carried out. So, children with special needs are going to encounter up to 4 times the interactions with adults compared to a typical child. So we've talked through some of these specialties. This is therapists, teachers, paraprofessionals, counselors for children who have significant language delays or are deaf or hard of hearing. They may use interpreters. And I will say, in the deaf and hard of hearing community, they have really gone above and beyond to try to give education to children and their parents, because they know how vulnerable those children are, given that they do not have, especially in the beginning, a consistent way to tell anyone anything. And I think that all, different organizations that work with different developmental diagnoses need to follow in that same pattern, because the deaf and hard of hearing community is going really out of their way to try to be more protective of their children and their families, so that people who are responsible for communicating for them don't have that power over them. So when we think about telling our kids, who is a safe and familiar adult, who is in charge of your body, these are very different things for them. safe and familiar adult is probably going to be 20 people. And that's not how we want it to be, but that's just what they're learning over time. This is our doctor, and we listen to Dr. So-and-so, and this is nurse so-and-so, and, this is Miss Kathy. She comes over and does speech every week. And, we usually get invited to their birthdays and to different celebrations. You get integrated into that family system because the family is so appreciative of the help and the support. And if an offender happens to be in that pool of people, it is just reinforcing to that child, this person is a part of your safe zone. And when we think about that rule of your body belongs to you and you are the boss of your body, unfortunately for this population, that's not true. If they don't like it, they don't want to do it, we push them to do it. Now, again, it's to help them with developing skills. It's for a reason, and there's really not a good way around it. But unfortunately, the standard prevention language does not apply to them because of these different situations.
So we're going to go into trauma processing, and I'm sure some of this will be review for you in terms of understanding how trauma impacts the brain, but there were some special or some specific questions around how trauma impacts the brain of kids with special needs and how that may show up for them. So we'll talk about that, and you'll see that and some of that you're going to have to assess out. So unfortunately, just like with any young person, you have to assess out how trauma shows up for them. And in this case, what we're hoping is that when we give you an idea about their brain structures in the first place, that will help you kind of decipher what's going on and being able to separate out, is this trauma or is this special needs? So one of the questions that we did get asked, though, is how can you tell the difference between trauma symptoms and developmental delays? And unfortunately, sometimes they show up the same way. So when I do training on interventions with traumatized populations or kids who are struggling, and I have teachers or educators asking me, how do I know if they've been traumatized or not? I say it doesn't matter. These are strategies to address behavioral issues, and they're shown to work for that. It doesn't matter what's the source of the behavioral issue or the struggle with the young person, whether it's hardwired because of a special need or hardwired because of the trauma. So just something to keep in mind. So we know that trauma physiologically changes our brain. Here's a picture of a healthy brain and an abused brain. We know that young people who are exposed to traumatic events actually changes the synapses in their brains. And so this is always a picture we like to use to show folks that areas actually light up different. Again, we know that you know this, but it is going to show up differently in a kid with special needs because areas of their brain are going to be over or underdeveloped. And that's something really important for you to know, because how the lights show up, which is less of importance for the role that you do, but it's going to, when you talk about symptoms or how it shows up, they may be more pronounced in certain areas simply because that young person is overdeveloped in that area.
So I have drawn this beautiful brain map, and it is based off of the following slide, which I will be sharing with you here in a minute, that was developed by Bruce Perry. So Bruce Perry is a trauma psychiatrist. He developed the neurosequential model of therapeutics, and he has outlined kind of a brain map and just a way of thinking about how trauma impacts the different parts of the brain. For a long time with trauma, the primary intervention was CBT. And so, and nothing against CBT, but that was just kind of the area that we looked at. And then thinking about, what about younger children, or what about adults, or, children with special needs where something at that level may not be an appropriate fit. And so what he really looked at was, what part of the brain has been the most impacted by trauma? And that should inform how you are choosing interventions and how you are really tracking their trauma symptoms. So, the brain develops from the bottom to the top and from the inside out. And so the base of the brain is the brainstem. That is your primary regulation system. It is your survival center. It controls your blood pressure, your heart rate, your breathing patterns, your body temperature, your metabolism. It is also where your stress center is going to activate. And so everything is built on top of that system. So if you have a child who is born prematurely, that system is underdeveloped. If you have a child who is born with medical issues where their brainstem is going to be bombarded with more sensory information than it's expecting because of procedures and time in the NICU, that structure is going to be affected. Children who have the diagnosis of autism often have an overreactive brainstem, just meaning that they secrete cortisol at a higher level and are more likely to have delays in the structures that are being built on top of them. So that does not mean that all children with special needs have an immature brainstem. It just means that we want to be looking at what structure has been the most impacted, first of all, for development, but then second of all, by that trauma. The second structure is going to be that kind of midbrain diencephalon area, which is what we call the sensory motor part of the brain that controls coordination, balance, sensory processing, which is not the same as sensory integration. Sensory processing is creating a library of sensory experiences, whereas sensory integration is integrating those together so that you're still able to be a part of your environment. It's also going to control sleep, appetite, all of those kind of motor pieces. So we know that for a lot of children, when they experience trauma and stress related to trauma, we will see effects with sleep, with appetite, with how they are responding to touch, to sound, to changes in their environment. That is all lower brain reaction. And so when we are looking at symptoms, think about how deep in the brain those symptoms are being expressed. The structure that develops on top of that is going to be the limbic system, which controls all of our higher level emotional skills. So empathy, play skills, interest in toys, interest in activities, attachment, sharing, being attuned to others around you. It's also going to be how you react to stress and how you regulate your mood. So a lot of trauma symptoms we think of at this kind of emotional level, which is true. But for some children who have an underdeveloped limbic system, so to kind of go back to, let's say, a child with autism, where we know that the limbic system is obviously there and they have skills in that area, but the connections are not as strong, they may not have as much emotion or feeling around the abuse in terms of being, and not to say that they don't have feeling about it. So I want to be very clear here. When we think about how a person feels about what's happened to them, it requires some ability to be able to process your own feelings, and not just that, but to be able to understand feelings in other people. And because this is an area of delay, the way that they process their emotions around the abuse may look different than a typical child.
So how this may show up for you in a case. So I was interviewing a young person who I think after the fact, or maybe even during, she should have an autism diagnosis. We will talk about that a little bit later too, because I know that there are many kids that you see where your eyebrow might raise, where there's something else out there that they have not been formally diagnosed, or the opposite. They've been diagnosed and you're like, I'm not really sure that shows up for them. But as I think about some of our interview techniques, we certainly do ask about the senses, and we'll talk about that today too. But I was talking to this young person because I could not wrap my mind around the fact that nothing was said between her and her uncle, and she was an adolescent. And so typical questions I'm asking, I was like, so help me understand what you're hearing when your uncle is having sex with you. And she starts to tell me what he says, but it's in this really flat affect where she says, he tells me he loves me, and he asked if I loved him too. And I said, I don't know, right? And so there's an example of how that may show up, that underdeveloped limbic system. Or he would ask her, is this good for you? And she was like, I'm not sure. I've never done this before, right? And so it seemed somewhat robotic, and I was trying to wrap my mind around it in the moment, where really what was happening is all of the other sensory things, like the creak in the door, or how the carpet felt underneath her feet, or the texture of the sheets in the camper. Those were the things that she was able to talk to me about, as opposed to the interactions. But because my brain is so different than hers, and I was trying to extrapolate how they got from this room to the camper and what that was about, which that was not important to her. That was not making meaning of that, which would require the cortex in the limbic system, wasn't online for her. And so I was unable to get that and draw that from her in my interview. And then I needed to explain that, particularly because we couldn't get an autism diagnosis and we had to leave that out. It was left out of the court case we had to talk about just in general how she made meaning and how she engaged with the world around her.
And then finally, with that cortex area that Amber had just mentioned, that is the only part of the brain that is not primitive. So it is our only higher level structure, and it really controls all of our higher level skills: language, articulation, retention, recall, memory, things like executive functioning, where you complete an activity, you complete a task, and then evaluate how well you completed it to tell the brain if that's something you can do again. But we do this in microseconds. So this is something that can be very difficult for a lot of children because, again, we know that with children with special needs, depending on what part of the brain is most affected by that special need, it's going to make it that much more difficult for them to maintain a cortex level. So to operate at this kind of higher level cortex system, all of the structures underneath need to be stable. And so if you have difficulty with emotion regulation, that will drop you out of the cortex. If you have difficulty with sensory processing, difficulty with sleep, that will drop you out of the cortex. If your brainstem overreacts when you're stressed, or similarly underreacts where you dissociate, that will remove you from the cortex. The brainstem is a magnet. If it is not regulated, it activates and it will drag you away from the top towards the base. So you are losing skills on your way down. And we see this with typical children, and especially in high stress situations. I was doing a forensic interview with a child who was 4. As he was walking through the things that had happened to him, he was using less and less language. And then at some point, he was more dissociative. He started just lining up the crayons on the table and doing things at a repetitive level, which is a very midbrain type response. And then he laid his head down on the table and went to sleep, which is a brainstem response. That's a shutdown. And so as that stress increased, his brain removed him from the higher level all the way to the bottom. And so these are things that we're looking for, not just with children with special needs, with all children who have been traumatized, but we are going to see it in a different way depending on how stable those structures are to begin with. Because if they're not very stable, you can drop from the high level to the low level pretty quickly.
And this is where CBT, we're going to show you another picture. So this is Bruce Perry's map. And what's nice about this is it really kind of highlights skills at different areas, yellow being the cortex, prefrontal cortex, purple being limbic, blue being midbrain, and then pink being the brainstem. And so I like to use this quite a bit when folks are trying to ask young people to do things, whether they have special needs or not. When you're asking somebody to do something and they're unable to do it, and then we get into this push and pull depending on your role about resistance or disrespect or different things like that. We look at these things, and some of those higher level things are the first things to shut off. So what we need in order for CBT, specifically trauma-focused CBT, to be effective is we need the yellow part, or the prefrontal cortex, or the cortex, to be lit up. The only way that I can assess my cognitive distortion is if I can actually think about it concretely or abstractly. And so when we find that some of these systems or these models aren't working, it's because we can't even get people into their cortex in the first place, or they're in their cortex when they're in session with you because it's safe and calm. But when the event occurs, they're out of their cortex and they're in their limbic system, thus repeating the kind of maladaptive patterns that they've learned over time. We see this across everybody, people saying things that they don't mean and saying they're sorry. And then once they come back into their cortex and they say, I'm sorry, I didn't mean that, I won't do that again. And then they repeat it again, right? You may think about those times in your own life and that is an example of the lights kind of turning on and off in your brain. And what you can have access to, because when you're so angry or frustrated or dysregulated, you don't have access to that part of your brain that says, oh, I promised I wouldn't say this again, or, oh, this isn't how I should behave.
So just to kind of, while you have that brain map in your mind, and when we're talking about trauma processing, this absolutely affects all people who have experienced trauma, regardless of developmental need. So traumatic events are going to impact the entire brain, of course. So you look at all those different levels: your stress response, which is in the brainstem; your sensory response, which is in the midbrain; your emotional response, which is in the limbic system; and then your higher level understanding, which is in the neocortex. And so the entire brain is affected, but primarily, and this is for all people, it's going to start in that primitive area because of the stress. The stress is going to drop you there, and that's where it's going to start really informing significant, memory or neural pathways to retain that information.
So somebody asked about what advice we can give working with those with acquired brain injuries. And so I think you would look at that the same way you do any kid. So or any person, when you're looking, if you can figure out, which will take some time, what part of the brain is affected, and then you adapt from there. And so essentially you're going to use, once you identify where the brain injury has the most impact for this person, then you'll strategize from there using some of the things that we're talking about today. So knowing that somebody can either do this or can't do this. Is it, how long ago was that? It was just a few minutes ago. So somebody said to ask us to repeat the last point, and I wish I knew what point that was so we could repeat it. But back to brain injuries. So what you have to do is you have to do some legwork to really figure out what part of the brain is the most impacted. And then from there, you'll have to develop and figure out how you're going to work around it and how you may make meaning of it, right? So it's like you have a puzzle, and how do I make do without this piece of it? How can I make it a collective? How can I create functioning without this certain piece? In addition to that, somebody had asked, really the doozy of the day, how do you work with somebody who's blind, deaf, and mute? And I have no idea. So
when we think about the work that we would do with a child who has been abused, who is delayed in all, kind of primary ways of communication or interaction or expression, one thing that's really, important to remember, and Amber will talk about this a little bit more at length when we discuss forensic interviewing, is for a forensic interview to happen, they do need to be able to communicate with a 3-year-old skill level. Now, for some children, that may be sign language or things like that, but they do need to be able to process information at least at the developmental range of a 3-year-old. And so, unfortunately, not all people who have experienced trauma are interviewable. And so that is very difficult. And you can imagine for those families that they're not getting a lot of justice. And so that reinforces to that community that it's not worth reporting. Now, I will say with intervention, and we are going to talk about this more at the end as well, it does not mean that there cannot be trauma intervention. There is even a field that we call infant mental health. Infant mental health is not the therapist having the baby lay on the couch and tell them about their mom. It's the therapist looking at how that stress is being expressed in their life. And so a lot of times for people who have diminished ability to communicate or diminished capacity to process that information, then we start at a bottom-up approach. A bottom-up approach is looking at how can we help with regulation? Where do we see them becoming dysregulated? And let's try to understand what's dysregulating them. How are their normal routines being affected? Sleeping, eating. Let's work from there. How is their sensory processing being affected? Let's work on desensitizing that heightened response related to stress. And the thing is that as we build up, we can start seeing if more expression at an emotional level, at somewhat of a cognitive level is coming out, and then we can treat from there. But in my opinion, with all people, we want to look at that base and work up. But for children who have really high level impact where we're not totally sure what they experienced, it is always going to be best to start with primary symptoms at a lower level and work up. So sometimes that is going to mean collaboration with outside disciplines such as occupational therapy, who specialize in sensory processing disorders. It's not always going to be appropriate for a mental health provider to be the first person that they start with. And again, we'll talk about that later.
Well, I'm thinking about the body remembering and what that looks like. And so it's something that we have a really hard time getting over because we may not know the why behind it. But there is not lost hope in terms of we can still build from there. We just may not get the interview. We may not know the how and why we landed here. We just discussed that. Okay. So we know, and I know you know, that abuse is first and foremost a sensory experience. You know that when it comes to interviewing or treatment, there's not, right? So trauma memory is disorganized in nature, just in general, that's the way that it is. We know how to solicit that memory is usually through asking sensory questions. What we want you to make sure you pay attention to is Courtney and I created kind of a brief that talks about the different senses. I realize that you understand the 5 and that you learned those probably in elementary, but you'll notice that there's some 3 additional ones that are on there, and we don't have time to go into a great amount of detail, but in the handout that you were given, it talks about what you're really looking for, and these 3 are particularly important for kids with special needs. Also, the handout, I know as an interviewer for a number of years and a child welfare caseworker, again, I mentioned this, that there are times that you actually have no idea if there's a diagnosis, or maybe there should be and they haven't been assessed. And so the handout also walks you through, like, what are some hints that maybe some of these things are coming up? And so even if I don't have a diagnosis and I'm going in, some stuff is coming up in an interview or in an investigation or assessment. And so I can kind of go with it based on the information I'm getting from the young person in that moment and how I may collect additional information outside of my typical response. Okay, we covered that.
So, sensory information is informed by regulation. So that just means that the more regulated your brainstem is, the better that midbrain that's sitting on top of it can actually accurately process, report, store information from your senses. Because we know that some diagnoses are going to affect that, it is going to create what we consider a sensory processing disorder. Now, that can happen to children who don't have a larger developmental diagnosis, such as autism or Down syndrome. It can just exist on its own. And again, for those children as well, their experience of the abuse is going to be majorly impacted by how they process sensory information. So when we think of, we think of kind of accurate sensory information, and then we think of a brain over-reporting it, meaning it's sending it way too much. That threshold is set too low, and it's letting way too much information in at a time. So kids who think everything is too loud and they cover their ears, or kids who can't tolerate certain textures and they pull it out of their mouth, they won't touch it. Their brain is giving them way too much information and it's making it intolerable or aversive. Whereas other children may have underreporting sensory processing, which means that the threshold is set too high and the brain is not letting enough information in. These are kids who may not hear their name called at the top of your lungs, or children who, I had a child that I worked with who was, standing on Legos and didn't realize he was standing on them. And so again, their understanding of how touch or pain is really going to be informed by if they overreport or underreport sensory information. And for most kids, they can have something called indiscriminate sensory processing, which just means that they can overreport some experiences and underreport some. So it's not that if your sensory system is overreporting, it's going to do it for everything. It will do it for specific environment, situations, and specific senses.
Again, on the handout, it gives you some more examples in that definition, since I'm sure you didn't get a chance to write it down. But the handout talks about overreported, underreported, and of course, indiscriminate is very, very difficult because you're going to think one thing and then the kid's going to surprise you in the other direction. So briefly, because I know that I want to make sure that we have time for additional questions. So again, I assume the senses: touch, taste, smell, sound, sight. We typically ask kids, what'd you see, what'd you feel, what'd you hear, all of those types of things. Proprioception is really understanding where your body is in relation to space. So pressure and compression you may be looking at. The handout has some examples about how you may ask that in a forensic setting. Vestibular is kind of what's happening in your inner ear and head position. And so this is really what's happening for folks who get car sick or on a boat or something like that. So you're really looking at detaching movement or motion or balance. And then interoception is feeling inside of the body. So this, I think you probably get sometimes from kids. We know little kids, when you say, what did it feel like? And they may say good or something along those lines. What we're really trying to understand is like if they're having a bellyache or a nausea or something, what's occurring inside, if they can feel their heart rate kind of beating. And again, that's one that sometimes shows up accidentally when we ask how they're feeling, but it's an additional thing past touch that we'd like you to consider. So So when we talk about what is the number one deterrent to an offender when choosing a potential victim, we know it's usually around disclosure or having safe adults to talk to and that they're believable. Again, we know we're preaching to the choir here. I think the major take home of this first section is really about we have to rethink how we do prevention education. We have to make sure that parents understand, parents think that their kids are not appealing to predators or sex offenders because they don't like to be touched, which we know is not, it's just not a thing. So we want to make sure that we're really being clear about how we're doing intervention for this group. As far as the handouts, we'll make sure that Kelly gets it to you.
I think she's sharing it at the end.
Oh, okay.
So, and just kind of going back to what Amber had said about offender behavior, I do some training for families of children with special needs on abuse prevention. It is not a popular topic because they don't like to think about it. They have so much stress on their shoulders that it's just one more thing that they have to be concerned about. Unfortunately, then they can avoid it. But I've worked with other parents just interviewing them specifically to ask, why is this something that you are not interested in learning about? And I had a mom tell me, well, my daughter has Down syndrome and autism. And she said she gets dysregulated easily. She screams all the time. She would not be appealing to an offender. She said, I understand that maybe some children with Down syndrome might be because they may be sweeter, they may be better regulated, but because she has the added component of autism, she's very dysregulated. So I don't worry about her the way that other parents with children with Down syndrome might worry about their kids. And I said, but have you ever thought, because she's always dysregulated, she would be a very easy target because it would be very hard to tell the difference. If she's in the other room with the therapist and she's yelling or crying, but she's always like that, that's really not going to alert you that anything's going on. And, she had not thought about it that way. And then she told me, and I don't want to. And I understand that. But the way that they're kind of looking at that information and, kind of going back to some of that brain piece that we're going to carry through the rest of the end of this topic is just, again, some of that lack of understanding on everyone's part of how their unique neurodevelopment is going to change reactions to trauma, reactions to offenders, reactions to pain or different things like that, reactions to their family members following something like that. Because if you have a family member who has not stopped intervention, whether it was for therapy or medical, because it was on your behalf, you're not looking for them to stop other things either. And so, we just want to kind of keep that final piece in mind, at least for the community part, because we're going to be wrapping up here with the forensic interview recommendations and the therapy recommendations. But we really want to keep that focus on education, not just for ourselves and other providers, but education for these families.
Okay, moving on to the interview. So we also want to remind you that this is just an introduction. So as much as Courtney and I like to fit in and shove in as much information as possible into 60 minutes, we know we can't give you everything. So keep that in mind. So again, remembering trauma is sensory, and we are not going to go a whole lot into the brain science. Again, we're assuming that you have some, and then what we had was review. But we'll hit a little bit about executive functioning, which again, that is that cortex level, and thinking about how executive functioning skills are greatly diminished during periods of trauma and abuse. And so this complicates things with typical functioning kids whose brains aren't fully developed anyway, right? We see this when we're talking about work with schools and when we need kids to show up to learn, and when we're having conversations with them about different things, and when their brains aren't supposed to be there anyway, or something is disrupting that, whether it's a trauma or neglect or some other type of marginalization. It makes it very difficult to have conversations with young people about what has happened to them, and so we can do something about it. So again, remembering that that these skills are greatly diminished, and part of our role, particularly in interviewing, is understanding and trying to help them stay in their cortex in order to access some of that information. So, and we know, any of you who's ever spent time with a preschooler knows that young children and children with developmental disabilities are likely to reenact elements of the abuse, right? And that's where we get our accidental disclosures. So you're going to see that same thing here. What may be frustrating, though, similar with preschoolers, is that you may not be able to figure out where that's coming from, and that's, of course, going to create some angst in that we may not be able to get justice depending on what's going on. But rest assured that there's certainly good treatment out there for the young person to kind of come around. And as we build up areas of the brain, we're hopeful that we can gather more information. So how we'd like to spend the rest of the 3 minutes, apparently, is to give you some brain maps. So we're going to go through and we're going to show you these brain maps. And essentially, this is just going to tell you, based on 4 different common diagnoses, what areas of the brain are over and underdeveloped. And we hope you will take these. We have absolutely given permission for you to receive the PowerPoint, so you can look at these. So if you know you've got a young person with autism, for example, or you anticipate or think maybe you do in the room, you can maybe take a break or something to say, okay, so here are the areas of this kid's brain or this person's brain that is overdeveloped. So I can really rely on these things when I'm trying to gather evidence. Or when I'm trying to treat somebody and how to make sense of the situation. And here are things that I cannot rely on. And so if a district attorney or a judge or a jury or an investigator or something is looking for these things, and this kid or this young person has this diagnosis, there's no way you're going to get it. And it has nothing to do with your interviewability. It's just that's not how their brain works.
And, essentially when you're looking at this map, I just want you to think of brainstem and midbrain are going to be this lower level. This kind of middle region is going to be limbic, and then this higher level is going to be cortex. And when you see something that says overreactive NS, that stands for nervous system, just for your own kind of reference when you're looking at these maps.
So an overreactive nervous system, in kind of layman's terms, you kind of all know what that feels like when you're feeling pressure in your chest or you're kind of hyper aroused. Many of you are hyper aroused just based on the work that we do, right? So it's that kind of feeling and kind of being on alert. So overreactive nervous system is kind of like hyper arousal, where an underreactive nervous system is kind of like hypo arousal, where this is where you're kind of lethargic, or when we see kids under desks or hiding or different things like that. So we know autism is what I think you probably see most of the time. So exceptional visual and spatial memory, ability to repeat phrasing word for word, and linear thinking. So this is great for an investigation, right? If you can get to this point where they're talking about, they're saying verbatim as opposed to giving you a synopsis, which most kids do. And depending on what their eyes are set on in a room or in a situation, they might be able to give you to the exceptional detail of something they're better than anyone or me even telling you what's in my office in great detail, even though I'm in here every day. I think you probably know by trial and error, the young people with autism have difficulty defining emotional experience and understanding emotional perspective, uncomfortable with close proximity. So they may kind of sit on that, and somebody being in my space, somebody being in my space, somebody being in my space. And so you'll have to kind of parse out a little bit the difference between Courtney being in their space versus somebody else if you're trying to sort that out. Difficulty reading social cues. So you're not going to really understand, or you're really not going to get grooming out of this group. They're not going to really understand it. Disorganized sensory processing. So they're not going to be able to necessarily, even though they're linear in thinking, I don't know that they're going to be able to give you linear sensory thinking. So they're not going to be able to share with you, first I felt this, then I felt this, and I felt this, even though that feels kind of counterintuitive since both of those skills are there. And perseverative under stress.
So, in the
another question. Keep going.
Oh, sorry. In the effort of time, we have this listed out for you, and we have a couple of other examples. So, this is just for you to be able to look through in your own time. So, we have Down syndrome in the forensic interview. We have Williams syndrome in the forensic interview. So these are just examples for you to look at and reference. This is not something that you should just use as a standard approach just because this is a diagnosis. This is just a way of being able to conceptualize before going in on a case of how we really want you to think about approaching a forensic interview with a child with special needs. And then ultimately, really looking at environment. And this applies to therapeutic intervention as well. Environment really may not be appropriate for all kids. They may not like fluorescent lights. They may not like sitting in a chair that's hard at a hard table, or they may prefer that over something that's soft. So we always want to be thinking about looking at the environment from a therapeutic standpoint, but also from a developmental standpoint of what is the most appropriate, what's going to help them be the most regulated in those base structures of the brain, so that we can get to this kind of higher level information. Lucy Miller, who she's the founder of the Star Center, which is actually in Colorado, but she also wrote a book called Sensational Kids. And she really advocated, because she collaborated a lot with Bruce Perry, for having things that she called sensory nests in therapy and forensic interview rooms. Now, a sensory nest may be a pop-up tent that has pillows. It may have a box with fidgets or chewy tubes or squishy balls or things like that, and that the child is able to decide if they need to go into a space like that to limit information, to be able to give themselves input that's regulating. And she said that this is really essential for trauma treatment, because a lot of the therapy environments or forensic interview environments are not conducive to supporting the sensory system. And since that was her area of specialty, she really pushed that a lot. Her book is great. I highly recommend it if you're interested in learning a lot more detail from a scientific perspective about sensory processing disorders. And again, her name is Lucy Miller, and the book is Sensational Kids.
Well, and that many schools are going this way to make safe corners and stuff like that. It's along the same lines. I think being trauma-informed with kids with special needs isn't that different than being trauma-informed or healing-centered in general. Again, it's just understanding the brain science and kind of what's going on for that kid in that moment, and what they may need and how they engage with the world around them.
And then we do just want to wrap up with this final point about treatment. So treatment is not a one-size-fits-all approach ever for any child, especially with trauma, but for children with special needs who have experienced trauma, it's really going to be a team approach. So we have an organization out here called Arc of Aurora, and what they have done is they have provided funding to have panels when there are cases involving children with special needs. And so they have an agency that treats the forensic interview and the treatment for those children. And when a child has identified special needs, that board or that panel meets, and they discuss things that the treatment provider should be aware of, or the forensic interviewer, or the investigator, or the prosecutor, so that they have a lot more support. And they have large panels in the sense that they can call on different people for different specialties. This is definitely the way that you want to approach treatment, because even if you specialized in working with children with special needs and trauma, you don't know every special need. There are thousands and thousands of them. And so you'll need to connect with that child's treatment team, whether it's doctors or developmental therapists, before beginning. They're going to give you a lot more information. And as we discussed earlier, depending on their level of understanding with the trauma and the symptoms they're expressing, a mental health provider may not be the best primary treating provider right out of the gate. It may need to be someone who works with regulation and sensory processing, which is going to be much more in that vein of occupational therapy and sensory intervention. And then when we look at activities that are most appropriate for intervention, if a child has limited ability to process information at that limbic or cortex level, you really cannot do a top-down approach. Things like CBT or TFCBT are not going to be appropriate until you start seeing language and understanding that matches what some of those interventions would be. So a lot of alternative interventions such as art therapy, music and movement therapy, yoga therapy. These have been found to be very effective, not just for children with special needs who have been abused, but for a lot of children with trauma. But these are things that we want to consider. And of course, because those are specialties, that may require you to refer them to that person before your part of the work is able to begin. And always thinking about what is the primary symptom of the trauma in this moment, and then addressing that and moving on to the next.
So we are so grateful for you letting us share what we know with you. It looks like, for the most part, we hit all of the questions ahead of time. I printed them out and was crossing them off as we hit them, but we are open for more questions.
Thank you, Amber and Courtney. So I just wanted to go ahead and remind everyone that there's a little Q&A button. I know a few of you have already used it, so I'll give you a moment to think about if you have any more questions. I did receive quite a few questions about the handout. I have that, and I'll email it to everyone who attended, so you'll be receiving that. We also recorded the presentation. It'll be posted on our site, so you can rewatch it. So we'll
Fun
just
for you.
So we'll just give everybody a moment, see if they wanted to ask more questions, but you did pretty much address all the ones that were asked earlier.
Courtney and I are a good example of, so Courtney's a trauma and special needs expert. However, my area of expertise is trauma as well, but in terms of investigations and assessments. And so we've had a lot of fun kind of combining, and I've learned lots from her and vice versa about how her work can show up in an investigation and how we may use it to get justice for this population. It is so difficult to get justice for, just like when we see little tiny people who we know something bad has happened to and we can't do anything about it. It's the same feeling of helplessness and hopelessness around it.
So we haven't, oh, another one might have just popped up. Oh.
She just said we were amazing and wonderful and wants to be our best friends.
Thank you very much.
So if we don't have any more questions, is there anything else you wanted to add?
No, I mean, I just think, again, with this population, looking at alternative resources is going to be really big. We have some resources that we've placed in on the reference part of our slides, but Bruce Perry's work is really important in this field. Bessel van der Kolk wrote a book called The Body Keeps the Score, which really looks at, again, those lower brain structures and how those are impacted by trauma. And he wrote this just for trauma in general. And he's also a huge advocate of yoga, EMDR as treatment, things like that, probably EFT, different things. So, I think if you are interested in, if you're obviously interested in trauma, if you're working with this population, you're in this webinar, but if you're also interested in working with children who have just different neurological development, reading things written by not only trauma experts, but also written by people who are just experts in that field of sensory processing, like Lucy Miller. She's not a trauma expert. She's an OT. She's a sensory expert. And so, I think that's something that's really helpful, is just attending conferences that are for early intervention providers. That will give you a lot more information and background, and it will definitely make it easier for you if you work with a child advocacy center or a therapy center to connect with the special needs community, because for them to start reporting more and bringing their kids in more, even if it's just for treatment and it's not something where they can get an interview, we want them to feel like the trauma community is there for them as well. They feel very kind of left out in the cold by themselves.
Well, and think about any of you who have private practices or who are treating just general trauma populations. I think you should consider OT and some of these other alternative therapists anyway. And I think you probably already know that in terms of the body having that memory of certain things, or how that shows up for people. And so hopefully this is just some additional validation to get some other types of therapists on your referral list. I think this is also helpful for people who are engaging in maladaptive or dysfunctional behavior, and we don't really know what it's about, and helping them work through some of these things physiologically, and then it might be able to give them some more language to what's happening. So it's just reminding ourselves, which we do quite a bit, is that we're still kind of primitive beings, and how we can play into that in order to support folks getting into their cortex and being able to share their experiences and how we can help them heal.
So we just got a question from Kelly. Do you have any suggestions for a prevention program in getting parents to attend or encouraging parents to attend a training? Yes. So, like I said before, parents of children with special needs are reluctant to come to things like this because it feels overwhelming and stressful. And so what I usually suggest starting with is just the kind of lighter side of prevention, of how parents can help their children understand their bodies. Even talking about general safety, when the police department or the fire department have, those safety days, it's usually involves kids like riding their bikes around cones and climbing up on the fire trucks and things like that, which is great because it helps kids see the firemen and the police officers as there to help them, that they can trust them, that they're, approachable. But a lot of the activities are not structured for children with special needs, so they don't go. And so what we want to do is start with fun events, start with things that can bring them in. Different community organizations have adaptive playgrounds, and those are for children with special needs to be able to access. And so even having, parent meetups and things like that is going to be important. You have to start with the rapport first, because if you just come out with, this is prevention education to, prevent abuse of children with special needs, you're going to get a lot of special educators and therapists who are interested, but not a lot of parents. And so the parents need to feel safe. They need to feel that they can trust you, and you need to start with something that's easy to swallow, quite honestly, and
so
then go from there.
No gruesome pictures, like human trafficking with chain, none of that. You really want to normalize in terms of talking to them about helping their kids understand their bodies and how it works. And and I think easily you can integrate, I'm sure many of you have had at least a handful of cases where what has happened is you have a child with special needs who offends on another young person because of their developmental level or how their brain works, or they can relate to that person differently than kids their own age. And what often is the culprit of that is that they have changing, developing bodies. They still have arousal patterns like the rest of us, and nobody's given them any outlets to use those. And so you may be able to get into those with adolescent populations, perhaps. I know that is too late in our minds, but perhaps you can start building rapport in those communities by going that way to help kids understand puberty, because that still occurs.
And I will say, always, if you have questions about integrating prevention education into the schools for children with special needs, go to the special educator. Their whole specialty is about adapting curriculum. They can help you. They will tell you, show me what you typically present, and I'll tell you what we can do with that in this classroom setting. They're a great resource, and they are really committed to this community of people. They want to help, they want to be involved, and so access that.
So I love those people as well for typical functioning kids. When I do a lot of trauma work in schools, I find my special needs folks because they do so much regulation work. So we got another question. Oh, we don't. Thank you, Kelly, for your comment.
Yes, and thank you for being open to, reaching out to that community. They really need people who will see them and will make them feel like they're part of this, the community they live in as well, and that we as providers are here for them. So so thank you for being open to that. And any other questions before we wrap up?
We've lost a good chunk of folks, so I wonder if people must be done.
Well, thank you to our experts, Amber and Courtney. Really appreciate you taking the time, and thank you everyone for joining us today. Like I mentioned before, we'll send out the handout that Amber and Courtney had mentioned. Okay, thank you.
We're so grateful for your work. Thank you.
Thank you.
Thank you.